Hello, dear colleagues and fellow nephrologists, and welcome to Live 2021 Nephrology Campus. My name is Christoph Wanner. I'm chairing this webinars together with my colleague, Professor Peter Stenwinkel from the Karolinska Institute in Stockholm. I'm located at the University of Wuerzburg here in Germany. So you are followed today webinar number 13 out of a series of 18 webinars about current trends in nephrology. You are listening today and you can ask questions all the time, but you are invisible and you are muted automatically. The questions can be put in the questions window of GoToWebinar in the right bottom corner. Another announcement maybe for today is that at all the end of the 18 webinars, we have a Live 2021 Congress in September 15 to 18. So you can register and follow this Congress, and I will announce it again at the end of today's webinar. So we have today two renowned speakers. It's my pleasure to announce Ariane Zaloszyc. She is from Strasbourg University Medical Center, and in my announcement box here, she is or belongs to the young nephrologists for the future of nephrology. And I'm really looking forward to hear her talk. And we have also with us Professor Wim from Biesen, a colleague and chief of the Department of Nephrology at the University Hospital in Gent. And both will talk about the overarching theme of approaches to tailored dialysis modality choices. So for the first talk, I will now invite Ariane Zaloszyc, and she will have her first talk with the presentation. And please, Ariane, the floor is yours.
Thank you. So, good afternoon, everybody. We are going to talk about youngster on renal replacement therapy, RRT. The adolescent patients are facing specific problems. As you know, we are talking about an infrequent condition. Children and adolescents represent less than 5% of the end-stage kidney disease population. In contrast with a low number of patients, physicians are confronted with a high variability of situations in terms of age and size and underlying diseases. Predominant causes of ESKD in children are K-acute for 73% of cases in children under 1 year and glomerulonephritis in children older than 12. Some pediatric specificity is that children requiring RRT as infants are likely to have the 3 RRT modality across the lifespan. For those children with early onset of the disease, transition of care from pediatric to adult team can be challenging. So, which RRT modality can be applied in our youngsters? Transplantation is the best option in terms of survival and quality of life. Survival on dialysis is also good. There is no long-term difference in morbidity and mortality between PD and HD for children. PD is mostly used for infants. 17.3% of patients in children patients are transferring from PD to HD due to infections, according to registry. Despite major improvements in RRT modalities, mortality rate is 30 times higher than in the general population and is higher in the dialysis patients compared to the transplanted patients. CKD-MID is responsible for a high cardiovascular mortality and of a frequent growth impairment with a short stature in adult patients. Concerning psychosocial outcomes, young adults with CKD during childhood have delayed autonomy, psychological and sexual developments. For those patients, it is rare to become a parent. Still, 68% of children have an educational level similar to their parents. How is RRT modality choice made in our patients? For infants, the choice is made and applied by parents with clinical expertise and medical capacity, and it is also strongly dependent on level of family support. The burden is on parents and children for PD, diet, medication, hospitalization. For adults, they are making their own choice based on professional and personal life. How to manage adolescents? Are they able to make this choice? Should the choice of modality be made by the young patients, by their parents? They experience physical and psychological changes of puberty and have to learn to self-manage their conditions. The parents are still legally responsible. Adolescence is a very critical time. It is a period of transition starting from age of 10 and ending into the early adult years. It is often an unstable transitional state from dependence toward autonomy. This period is characterized by rapid changes in physical, cognitive, emotional, and social development and characterized by risk-taking behavior. Achieving this period is supposed to allow adolescents to get a sense of identity, an autonomy, a value system, to develop peer relationship and get a financial independence. This study in Australia illustrates this risk-taking behavior. For example, 2/3 of road accidents are reported in young adults. 33% of deaths in adolescents are due to suicide, and so on. The prevalence of chronic condition among adolescents is hard to assess. Some studies estimate that 10% of adolescents have a chronic illness. Chronic illness can lead to a difficulty in autonomy shift by increasing dependence on the family, but also to identity disorder. Maintaining peer bonds can be challenging. Patients with chronic illness can have fear of peer judgments and suffer of the social cost of living with illness. All these problems increase the risk of non-adherence and the risk of risk-taking behavior. In CKD adolescents, we have specific problems, such as bladder dysfunction due to the underlying urological condition. This can lead to problems for transplantation. The patient can also have a negative self-image due to urostomies and pouching system, and non-compliance with catheterization is a frequent problem. Non-adherence can be due to inadequate parent supervision or ineffective parents, patients, or parent-physician or patient-physician communication. Psychosocial specific issue are due to a bad body image due to the medication effect or procedures, to an absence from normal age-appropriate activities, i.e. school, and we know that we have a high depression rate in our patient. Even if transplantation is considered as the best RRT option, we observe the highest rate of non-adherence in medication in pediatric transplant recipients, with increase in graft failure rates beginning at age of 11 and peaking between 17 and 24. Patients with a functioning graft at age 17 have a 42.4 likelihood of losing the graft by age 24. Preemptive transplantation is not always possible. In this case, which dialysis modality can be proposed in order to avoid non-adherence pitfall? From a medical perspective, PD offers a lot of advantages. It favors residual renal function, preserves vascular access, it is compatible with school. The choice can also be influenced by geographic location. PD is the best option if the patient lives far away from dialysis center. From adolescents' perspectives, PD can be felt as long and lead to an inadequate treatment by shortening PD time. PD requires diet restriction and medication, as that can lead to non-adherence. PD can be difficult for the autonomy of our children and can be felt as hospital intrusion at home. What about HD? From a medical perspective, frequent HD or long duration HD improve clearance and outcomes. It allows for less restrictive diet and for growth catch-up in our children. It is made traditionally in dialysis center, and the medical team can be reassuring for patients. There are multiple partners such as social worker, nurses, teacher, and that allow for a good patient management. Despite legal issues in some countries, home HD for children is a promising option. For the teenager, HD can have disadvantages. HD schedule is not compatible with school attendance. Dialysis 3 times a week is more acceptable, but session tolerance can be lower. Patients can feel pain due to the punctions and feel uncomfortable with the dependence on medical staff and with being frequently at hospital. There is no perfect option. It is very important for children and teenagers to maintain a social life. And as you see in this picture, we are organizing social activity with parents and children on PD, and we have teacher in HD and fun activities for children. Dialysis is part of the life of children and should be part of the global life. For adolescents in dialysis, diet, medication, and time on dialysis are felt as freedom restriction, and physicians and patients can have divergent interest. This will lead to major weight gain between dialysis sessions, to electrolytes imbalance, and to the resulting complication we all know about. So, what can we do to improve adherence of these teenagers? The best options depends on each patient. We have to discuss before starting RAT to find which option is the best for the patient. We are confronting to failure. It is hard to accept, but it is also strongly dependent on the disease acceptance and on the family support. Some patients are able to cope with the disease immediately, and others are not able to cope immediately with the disease. We have to adapt ourselves to these conditions. The first line of thought is to work on disease acceptance from the beginning and to have education program to prepare dialysis, to work with multiple actors in our centers, to keep contact with school, to keep parents involved, and to shift step-by-step responsibility from parents to the patient. This article of Bayer et al. Proposed some strategies for increasing adherence of our patients. For our youngsters, RRT is lifelong. Managing RRT in adolescence is challenging. Dialysis is very central in life of a patient. For example, you can see the picture of this child. He was designing new devices at home. The patient have constantly to adapt. We also have to adapt to this transition time to try to find some common ground. Thank you for your attention.
Thank you. Very interesting, very work demanding, and I think a lot of work, and it's very interesting for us actually, for adult nephrologists, and I'm really looking forward to discuss this complex transition also from childhood to adolescence and further into adulthood. So thank you again, and everybody is encouraged to ask the questions in the chat, and I get the questions later on my screen, and you will also see it, and it's very comfortable actually for us and for me then to discuss the questions. Now we are coming to the second talk, and I welcome Professor Wim van Biesen. I already announced you, Wim, and I just go into medias res and I ask you to present your talk, and the floor is yours, Wim, please.
Thank you very much, Christoph, and also thank Ariane for the nice for my talk, because we will follow up more or less with the topic, because I will talk about living with advanced kidney disease and consider that as a lifelong journey. And as Ariane already introduced in her talk, we all know that people come with their end-stage renal disease and enter somewhere down the line in renal replacement modality, be it transplantation, be it peritoneal dialysis or hemodialysis. But as nephrologists, we all know, and as nephrology team, that sometimes people will have to shift and to transfer between these modalities. And this makes it all quite complex if we want to counsel, if we want to give advice to people on which modality would be the best for them at a certain moment in time. And then, of course, we would also be very happy to have enough research evidence to give counseling to these people and give them advice on how to do that. And we would like to have specific research evidence that admits or that permits to tell something about that individual patient's clinical state and circumstances, be it a youngster, be it an adult, be it an older patient or a frail patient, and all those conditions in between, that we can adapt the research evidence to that patient. And most of all, I think, and this is something that Ariane also already highlighted very much, we want to take into account the life of the patient, the lifestyle of the patient, and the life goals of the patient when advising on modality selection. However, unfortunately, reality is different, because we can tell something about probabilities of outcomes with certain modalities, but these, for example, this is from ERA ADTA registry, where you can see that the outcomes in PD and HD are quite comparable, but this is of course about populations. It's not about specific patients. And you can see that if you're going from DPD patient to the HD patient, and if you subcategorize fast transporters versus slow transporters, that the advice on what to do, being APD or CAPD, can already be completely different. So you can understand that if you're talking to an individual patient, this will not give you a very solid ground to base your advice on. The second problem is that, considering the fact that this is a transition, this is a life journey, it's not for one modality that you're giving them advice, you're giving them advice for the rest of their life, the rest of their careers. And we have little or no information on what happens with different successions of treatments, what gives them the best prognosis, the best quality of life in the long run. Better to start with the dialysis and then get a transplant, get the transplant first and come back to dialysis when it fails, etc., etc. At the end of the day, the evidence for that is lacking. For example, this is a study that has appeared for transition from PD to HD, and you can see that in fact in the outcome, the survival of these patients, nothing much happens. For months and months on a row, there is no difference in outcome after the transfer as compared to before transfer. Of course, this is data only applying to people that survived the first 60 days. So we don't really know, there is no good information, or there was no good information until recently about what happens in those transitioning periods, what happens in that period that patients have to transfer from one modality to the other. And of course, also important, if you're giving advice to people, it's very difficult to hide away your own feelings, your own emotions, to hide away the framing that we give. And we do quite a lot of framing. And at least we're not always clear to ourselves about that, but patients perceive it like that. This is a survey that we did some time ago in 13,000 European patients on renal replacement modalities. And you can see that the quality of the information is judged much more on hemodialysis, in-center hemodialysis, and on transplantation than on the home-based modalities, PD and home-based dialysis. So patients feel that there is a kind of reluctance, that there is a kind of, yeah, you can, but maybe not, against these home-based treatments. And this bias convinces them or deters them to do something which might be useful and good for them. And most important from this study, from this survey, was that the patients had the feeling that they had the complete information, which was adapted to their life and their life goals, and that they could take the decision themselves based on that information, were much more likely to be satisfied with the final modality they ended up on. And this is, of course, at the end, what we are doing it for. We want the patients to be happy and to be content with their life. And there is some tools that can help you to elicit this type of information. It's, of course, the topic of another talk, but if you go to the website of Yoda, just type in Google Yoda and dialysis, and you will come to it. You will see this is a very nice tool that can help you talk with the patient and elicit from the patient what are his life goals and try to adapt your advice accordingly. But coming back to our talk of today, if you want to look for epidemiology, if you want to look for outcomes of transition from one modality to the other, if you want to look for risk factors that predict the need for transition, if you want to look for risk factors that are associated with unplanned transition, then you're left in the blank. There is no data, there was no data on that. And this is the reason that we started the integrated project, which is an international collaboration of registries and people interested in the topic. And we wanted to find out what's the time frame of an ideal transition to which modality would be and which patients would benefit from such a transfer. So at the end, what we wanted to know is what are the key changing points in the career of the patient and where the patients would benefit from a transfer from one modality to another. And second, we were interested in how patients and physicians experience these transfers, because as we said, it's not only about numbers, it's also about the life and the quality of life of these patients. First of all, the good news. It's not because you're promoting home-based therapies, like in this case, PD, and this is from USRDS, where you can see that there is a steady growth over the last years in the PD influx. Well, despite the growth in PD, and then of course, there's the cynics and the skeptics say, yeah, you can convince more patients to go to PD, but then you get a selection of more bad patients, and this will have a negative impact on the outcome in terms of transition to HD and in terms of mortality. You can see this is not the case. The full black line here is mortality, which goes down. So more PD means less mortality, whereas the dotted line here pointing to transfer to in-center HD, it remains the same. So it is possible to convince people to go for a home-based treatment, to improve the mortality and to get a better or the same technique success while doing so. Important. Second question, is there a difference in the timing of that transfer? Does it make a difference if patients transfer in the early stage of their modality, whether if it's in the later stage of that modality, does that differ in impact on their outcome? Well, you can see here the timing of that transfer. Yes, there is a big hunk here in the beginning, the first 3 months, and then it's quite stable over the following months. And then, of course, there is again an upward stroke at the end of the treatment after 10 years. And this means that indeed it's a biphasic thing. In the beginning, the reasons of transfer are completely different from what happens later on. And this is what we also see in the iPod PD study, which has, in the meantime, several publications coming from, where you can see that about a quarter of the patients that were in this prospective cohort of incident patients transferred to hemodialysis. And if you look to the reasons on why they transferred from PD to hemodialysis, then you can see that the major reasons are infection, peritonitis, as a reason by itself. And also, if you look to the other categories, the majority of others are related to some form of infection. And of course, inadequate dialysis, meaning ultrafiltration problems or real clearance problems. So again, it might be that not only the timing, but also the reason of transfer, either peritonitis or something related to the clearance and the ultrafiltration of your patients. And this has, of course, to do with the loss of residual renal function, the decline of residual renal function in their career, that at some moment in time, they will need to transfer. And this makes clear the difference. Peritonitis as a sudden event, you cannot predict it, whereas a transfer because of an adequacy problem, decline of residual renal function, deterioration of your peritoneal membrane, it's something that's gradual and where you can predict the transfer and where you can plan that transfer much better than in the infectious case. So yes, the reason and the timing of the transfer, it might have an impact on the outcome, and we need to be very vigilant to that. If your patient is not doing well in the beginning, if there is a lot of trouble, you can transfer him. If the patient's adequacy is going down, you have to plan the transfer, because otherwise there will be problems. But of course, peritonitis, you cannot predict, and there will be no way that ever you can plan a transfer after a peritonitis. Okay, now, does the transfer lead to an improvement in outcomes? Well, this is what we analyzed in the quantitative part of the integrated project. And you can see that in the 4 registries, the ANS data, the CORE, the ERA ADTA, and the USRDS data, that over the time, well, the numbers are quite stable. And you can see that USRDS, the switch to HD was much more pronounced than in the other cohorts. And also in terms of mortality, the numbers were quite good. And all of these registries show, if anything, an improvement in outcome. But again, USRDS has a higher peak and higher numbers than the other registries. But what is of importance from this registry results is that you can see that there is a biphasic, again, evolution of the mortality risk associated with this transfer, being very high in the beginning, and then after some months you can see it levels down and people come back to their baseline risk not being different from what they had before the transfer. But you can see, first of all, there is a higher peak in the beginning, and that the height of this peak is different according to the different registries. And if you enlarge the first part of the time frame of the previous slide, you can see that in the ANS database and the core database, that indeed there is a higher mortality in the beginning, more pronounced than in the ERA ADTA registry. And this has probably something to do with the reasons of transfer. If you're living in Australia and your dialysis unit is 150 miles away, you're probably less prone to have an ample and good switch and a rapid switch. You will be more likely to say, no, I will wait. And even if I have a peritonitis, I will go on and retry and so further. So it might be that in these regions, people are pushing the transfer beyond the limits, and that this explains why they have a higher mortality at the moment that this transfer actually happens. So yes, the timing and the planning of your transfer might make a difference. And this also reflects in this study where you can see that the cause of your technique failure, be it infection, nothing changes because your patient doesn't change. You changed the modality, but this didn't change anything to your patient or his general condition. If you're transferring because of inadequate dialysis or because of mechanical problems, which is in PD a bit the same, because of if you have mechanical problems, your adequacy goes down, then you see that there is an improvement after the transfer because you solved the problem that was related to the PD by transferring the patient to hemodialysis. Whereas if it was a social problem why the patient wants to transfer, then the outcome is even worse. You did not solve the problem because the problem was not the PD, the problem is a social problem, and that probably is enlarged or announced or highlighted by the fact that you transfer them to HD. So you have to be careful for the underlying reason. If you transfer patients and you intend to improve their outcome, be careful what you do. Be sure that it's fitting within the context of your patient from the medical side, but also from the social side. What is clear from all studies, in patients where you can plan, you have to make sure that the vascular access is okay. This is one of the major risk factors, and this is one of the failure points that we have in transferring patients from PD to HD, that will forget to place a fistula before the transfer can be done. Of course, again, if it's an acute peritonitis, this is very difficult, but in the case of residual renal function going down, this is something that you can plan and should plan, and that can improve the outcome of the patient. That were the numbers, but what about how do patients feel and how do the team feel about it? And can we help people to cope with these transfers? So this was what we wanted to know from semi-structured interviews done within the integrated project, what it means to the patients to change their modality, how they coped with this, and how we as a team can support them doing so. So we asked them 2 questions, and then there was an open, it's not a debate, but a structured interview where we transcribed verbatim. It's a classic qualitative approach. And what popped out of these sessions, these interviews, is that the transition process, well, it depends upon the timing. That's what we already said. It depends upon the scope, why these people were transferred, whether they were ready to do that, where the power lies. If this is patients that are very keen on their self-management, then of course the transfer to in-center hemodialysis, it's a disaster because they lose the control, they lose what they can put into the treatment themselves. But for example, if you look to what we found in the study, and this is published in PDI, that there is what we call a paradox of control. And again, this relates to the reasons why patients transfer. If you're transferred because you have a very complex PD regimen, because your residual renal function is very low and you're living to dialyze, the only thing that you do in your life is doing PD, being connected to a cycler and doing manual exchanges during the day, then you're very happy that you can come 3 times a week to the dialysis unit and be left out of dialysis for another 4 days of that week. Whereas in contrast, if you're doing very fine and you have an active life and you have an unmanageable peritonitis episode and you have to transfer because of that, this is a disaster. So there is a kind of what we call paradox of control. There is patients that are happy to give the control to the center. There are other patients that say, well, I want to keep the control myself. And this is, again, something that you need to take into account and that you need to incorporate in your approach to these patients, and that you need to elicit and to find out what the opinion and what the feeling of the patient in that context is. So if you're transitioning, I think this is the major conclusion of what we found from the integrated project and all from the complete integrated care approach, is that whether the treatment is successful or not, it depends upon the fact or on the way that you present it from the beginning. So you should always tell patients that there is different modalities and that it's very likely that they will have to transfer between modalities. This is not a problem. This is usual. This is what we can expect. This is not a failure. It's just a success of the strategy. Whereas if you push from the beginning PD by saying that hemodialysis is a bad modality, you're in trouble when the PD starts to fail, because then you have to transfer patients to the modality that you said, well, it was not a good thing, and that you used to convince them to start PD. So I think you should always be ready for a transfer. It's not because upfront things look good that at the background some things might be completely wrong. Never say never. Don't say that HD is wrong. Don't say that transplant is very good and that people should never come back to hemodialysis once you get a transplant. Never say never. And still a successful strategy, not a single therapy which you know upfront that it's very likely to fail at a certain moment in time. I thank you for your attention, and I think we will have a very nice discussion also with Ariane about this. Thank you very much.
Thank you, Wim. I liked the final conclusion. Always tell a successful story and be always optimistic. Very good. Mm-hmm. Thank you. We will have now, as you feel, the questions, and I ask also the studio to bring forward the questions which have accumulated. You, the audience, you will always have the chance, still ask questions, and please do so, and we can integrate them. So the first question goes to Wim van Biesen. It's quite a long one, but I'm reading it. After a failed PD, the logical next step for a patient already adapted to the home treatment would be home HD. Why is this modality, though, so rarely recommended? Are we missing an opportunity here?
I think that's a very good question, and it's a very puzzling question. I had the luck or the opportunity to review a paper on that from a very large center, and it was amazing that in their experience there was so few people from the PD program that ended up in the home dialysis program. And if you think about that, you say, well, why is that? Are we missing the opportunity? And I'm not convinced that it is the case, because it's, first of all, it's two different treatments. It's a whole different type of control. It's a whole different type of patients, I think. That's my personal feeling. Second, it also depends upon why patients have to transfer. If you're in the category that is fed up because you're doing your treatment yourself for 5-6 years, and all your house has become a hospital, and your family cannot invite friends, or your children cannot invite friends because there is a lot of machinery and everything has to be sterile, and so on and so on, and you cannot have a dog because this is dangerous, then you're glad to go to the hemodialysis unit in center. You're not interested in home dialysis, I think. So the reason of transfer, if this is burnout of the patient, also from the mechanistic view, if you look, PD patients, either you're on a waiting list for a transplantation in the younger ones, so you get a transplant and you're not going to go to home dialysis if you're on the waiting list and you know that tomorrow you can get a call to go to the transplant unit. So then it's probably more practical and more logical to go to in-center for the remaining waiting time. If you're an older patient, yeah, then why would you change? And why would you have a technique failure for your adequacy? Because that's probably not very relevant at that moment anyhow. And the home dialysis is more complex. So the most of the elderly probably are not able to do that by themselves. So we'll have to invite people to assist them. And this becomes logically, from the logistical viewpoint, maybe too complex. So it looks a paradox, but I'm not sure it is, because I think it's two different categories of patients.
It's also a question to Ariane. Maybe you have an additional comment, your own thoughts. Does it depend a lot on support of parents, or what do you have any additional things to the thoughts of Wim?
I agree with him, but the only thing is that now in France, it is not possible to make home HD for children. So now it's not an option for us. So when parents and children are motivated to have home dialysis, it will be PD. And I hope we are going to manage this legal issue and be able to propose to our patient home HD in the future, but now it's not possible, so it's not like that. But I agree that it's not a failure to go from one modality to the other. We have to and it can also be good for the patient to not have these hospital intrusion at home when they are adolescents. It's sometimes hard to have this intrusion at home. Yeah.
And maybe the audience, meanwhile, as you say, the example of France, the audience will have the answer because it's different in every country in Europe, maybe. Yeah, you're right.
Yes, that's
good.
It.
So I ask the studio to have the next question prepared for you, and it's coming in again for Professor van Biesen. Did you, in the integrated study, looked into the differences between males and females?
No, I don't think so. We can make it but I don't know the numbers by heart, so probably there will not be that much of a difference. I think we did the gender count, but there was no sex-specific analysis, if that's what you mean. So there was a kind of integration of gender, but it's not gender-specific, which is two different things. And that you make a separate analysis, males and females. Huh? Yeah, but gender was not a risk.
The sample size. Yeah,
it's very big because it's a combination. It's a combination of AMS data, the core database, ERA, EDTA, and USRDS. So the sample size is quite big. Yeah? So that's not a problem, I think. It would have been possible. Yeah. It is possible, yeah. But it's a good suggestion that we can do it. It's not a risk factor, but that's not the same as doing a separate analysis. Huh? And that's, but I'm not sure of whether we've done that.
And I ask for the next questions, but I have a personal, meanwhile the question is coming in, hopefully, I have a personal question to Ariane. Today we talk a lot about multidisciplinary teams. Is this something you also talk about in the pediatric field, or do you cope for every subspecialty because and don't use the multidisciplinary team? How is the situation?
I think it's depending on centers. In Strasbourg, for example, we have all subspecialties in pediatrics unit. So, for example, when we are using growth hormone therapies, we are asking for endocrinologist advices, and we are working all together. If you mean with adult team, we are also having a transition program with our nephrologist team in Strasbourg, and we are trying to make it better, but because it was not so good the last couple of years. So we are really trying to improve the transition to try to avoid this big issue of graft rejection in adolescents, because I think that maybe making the transition later or with a more step-by-step transition can improve this risk. So we are working with our nephrologist team. We are working with our subspecialty in pediatrics. That's sure, and we need it. I mean, we cannot work alone. It's impossible.
Depends maybe also on the size of the unit, on resources and what you have. So we have a question for you here, and this is a transition question actually. Do you hand over young patients to adult care when they grow into adults? How smooth have you found this in your practice, the transition phase? And maybe you can tell us also the age period when you transition them, what is ideal? Do you like to keep them longer in your pediatric field? Tell us a little bit about this.
I think it's depending on patients. We have some adolescents feeling uncomfortable with being in these pediatric units because they are starting a university, and they ask themselves to be transferred in adult unit. But most of our patients love to be in pediatrics because they are surrounded by nurses, work teacher, and we are maybe too much, but we are doing all appointment for a patient. We have very personal relationship with our patient because we have not so much patient like adults unit. So I think we are having very special relationship with this with a low number of patients. So it's easier for us to have this very individualized relationship with patient. For the transition, now we are trying to start when the patient is 16 to present them to the adult unit, but the transition will take years. So most of our patients are transitioning after 18. And what I know is that in different studies, it was we can see that if the patient are transitioning later, it's better for the adherence. So maybe it will be better to make the transition when the patient are 21 or 20, but I'm not sure you agree with that as an adult nephrologist, but I think it really dependent on the maturity of the patients too. If the patient is dependent on parents, it's better to be in a pediatric unit.
Yeah, I think we are very relaxed, but yeah, please, Wim, yeah.
Because I think we are building our transition program also now in our unit, and what we discovered or kind of experienced is that there is in fact two different things. There is the transitioning from a child to a young adult or an adolescent and to a young adult, which is a transitioning phase. And I agree with Ariane, this is something that pediatrics are probably more likely to do in a good shape, because you have more means and more experience and more people to do that. And the transfer, which is the actual handover of those patients to the adult clinic. So I think you need to distinguish these two processes. And we start, in fact, the transitioning already at the age of 12, where you have the gradual accustoming of the child to the fact that he will have to take his own responsibilities for his own treatment and his own decisions. And it's also an educational process for the parents, because we as adult nephrologists, we have more troubles with the parents than with the ex-children, new adults, youngsters. I'm not sure that maybe Christoph, you can agree or not agree on that, but mostly the parents are more problematic than the children, because they have been used to take all the decisions for the children, and you get a conflict between the new adults and the parents.
Yeah, that's.
Yeah, we in Germany, we have 7 programs sponsored by the foundation, the charity KFH, which invest a lot, and it's certainly of benefit. And we in Wuerzburg, actually, we have little experience. But tell me, Ariane, what is the waiting time for a transplant usually? I understand living donation, and even in Belgium, in France and in Belgium, what is the average time?
It's short, except right now with the COVID time, it's getting longer. But in France, it was 6 months on the waiting list to get a transplant. So it's a short time for infants.
Yeah, we could now also start the transition issues in the transplant field. This is a separate thing, yeah. And Wim, is the situation in Belgium also so
well, if it's a living donor, if it's a living donation, there is no waiting time. It's just the time for the workup of the parents, well, the donor and the child. And the waiting times for the children, I'm not sure, but I think it's quite short, no? It's not the same as for adults.
I think it's a bit longer in Belgium with your system and in Germany than in France. But now in France, it's getting a little longer than it used to be. It was very short, and now it's longer than before. But right now with COVID, it's very not good, the waiting time.
In Eurotransplant, they have a separate list, and this list has priority. Yeah, you're right. Good. I think we take the next question. The studio will have one more or many more, and to both of you. So let's give the lady the preference first. What is the best strategy for an effective and successful transition between therapies? Do you believe that patients should be choosing home therapies versus in-center therapies first, instead of choosing a specific therapy?
That's a very good question. I think if you're looking to the tool that we are using, the YODA, that the first thing is to try to elicit what the patient's life goals are. And then you need to decide whether this is more prone to be self-management rather than being managed. and how you can fit the different modalities within that lifestyle. And in that framework, I think choosing between a home-based therapy versus an in-center therapy is the logical first step to make. I think that's quite correct. So the distinction between PD and HD then at home comes as a second decision in that framework.
Yeah, as I feel with my experience is that there is lots of room to tailor the treatment also according to the situation, to the personal needs, to the environment, and sometimes less to science or to this question. Ariane, what do you think about this question?
For us, the choice will be made in terms of age. I think for infants, everybody will propose first PD because it's easier to manage. If the parents want to prefer HD, we are now able to do it with success, but still we are first, I think, proposing PD. Then for the children and adolescents, I think we can let them the choice. We have no difference in morbidity, no difference in mortality. We are able to do both. So I think really we have to decide with the patient and to see what is the best for him. Yep. I really think I will not tell that one modality is better for the patient than the other. Both but
it's extremely important.
I think I heard that we have, please, Wim, yeah.
It's extremely important, I think, to listen to the patient and what the patient wants, expects, what his expectations are, because I always tell the story. We had a trainee here and he was going to do a pre-dialysis education to the patients, and after 2 minutes he came out of the consultation. Oh, it's decided it will be hemodialysis. I said, what happened in 2 minutes? How is that possible? Oh, I told the patient that she needed a catheter in her belly to do PD, and she said, no way, I will never have a catheter. So it was decided we go to hemodialysis. And then I said, but wait a minute, how she's going to do hemodialysis? She will need a catheter in her neck. Oh, I didn't think about that. So you really need to be open to patients, discuss what patients want, what they do not want, and how that you can adapt your treatments according to what they want. And this takes time, it takes confidence, it takes a chat to obtain that information. And the important thing is that you need to offer all the portfolio. I think that's important, that you have it in your own unit and that you can really, with an open mind, say, well, this is all we have. Choose.
Good. I heard that we still have another question, the final one. So, or apparently not. We have run out of time, or what do I hear? Okay, so good. Now, anyway, then I'm happy with this discussion. And I thank you for the good discussion, the answers to the question, and give us a really clinical feeling how to manage this. And I see that you are very good doctors and the heart is at the right place, as we say. I hope you accept this. Thank you, Ariane, and thank you, Wim, for having us today. Thank you.
Thank you.
Thank you.
So,
see you later.
Now I think we transition to the next webinar, number 14. And we have a very interesting program next time. And we have 3 renowned specialists. We have Professor Andrew Davenport from UK and also Professor Simon Davis. And they both will discuss with Professor Bernard Cano the topic on sodium management in end-stage kidney disease and dialysis learning in nephrology. So this will be another exciting webinar, number 14, on our way to number 18. And all these webinars are available for you and on display and could be found on the website and in the internet. So finally, again, the announcement that after the 18 webinars, we will have the Congress, the Live 2021 Congress. And this will be happening in September 15 to 18. It's a 3-day program involving more than 60 specialists and as well the younger generation. And we have many renowned women scientists and men representing European nephrology with us September 15 to 18, and some surprises of very towering lecturers having overarching topics for us during September 15 to 18, and we prepared some time to have a good congress for you upcoming September. So I thank you for your attention, and we'll see you next time, March 11, with the sodium topic. Thank you.